home versus long-term care or assisted living, and we're thinking of, the amount of support that we can put in place and what their living environment is. I'm often finding I'm contextualizing that for patients, because I see patients who are more often deciding whether to go home or go to hospice, and we're talking about shorter time frames, but a similar sort of decision making is, I will probably be happier at home, but can I get the support that I need in order to remain at home? And that's a challenging question, and I sometimes contextualize it as like, we can put in people and we can put in things, and the balance of those, if that is enough for you to be happy there, then that is probably enough for you to remain at home. And I'm often kind of downplaying the idea of safety, which is where people, often families are focused, and what I've noticed is that the patients tend to be more focused on, they want to be safe, they don't want to fall and not have anyone notice or something like that, but they are very quality of life focused, and they're very much about their independence and their autonomy, much more so than sort of safety, I guess. Mm-hmm. And that's an interesting dynamic. Have you noticed that with your patients as well, in terms of the sort of conversations that caregivers are often having with their loved ones?
Absolutely. I think after you get through kind of the review of how one's managing and the supports you can put in place, and what one would accept, depend on what's suggested as well, is another question.
Right. Yeah.
It all comes down to, that everyone in a way is living at risk, but it's how much of that risk can you mitigate, reasonably, while still trying to preserve one's autonomy and independence as much as possible.
Yeah.
And every family unit generally has a different level of risk that they're willing to live with, and it's just identifying those thresholds, for themselves, and then making the decision based on that.
Yeah.
Because, a lot of, family members, and sometimes even us as clinicians, feel like a transition to facility care will mitigate all risks, mm-hmm. and will be the best place for people. And oftentimes it's just not.
Yeah.
Like, not all risks can be mitigated in facility care. And sometimes it is just not the better place for that individual.
Yeah, and the data backs that up. I mean, there's not good data to suggest that people have a longer prognosis in long-term care than they do at home, if you match those patients. So it's, this, which it should, if the whole idea is, we're going to mitigate risk, we're going to prevent harm, then, ideally you would have trials of, RCTs of institutionalization versus home care, seeing that people in institutions live longer, and it doesn't seem to be the case. Mm-hmm. So it's an interesting dynamic. Mm-hmm. And challenging, because we have this tendency too to sort of almost infantilize old people sometimes, where it's like, we know what's best, okay, now you need to be sort of taken care of, as opposed to thinking that they have this whole broad lifespan of time that has led to this point, and they have their own set of values and their own opinions on things, even if they're more frail or cognitively impaired than they have been.
Exactly.
Yeah.
And I think also the way that our system currently works, with essentially the accessibility of moving to a higher level of care, having such long wait lists, it is kind of an expectation of the system that family members or friends become caregivers, other people have to step in the mm-hmm. interim, and it at least has to be tried first.
Yeah, and it's sort of this weird dynamic. I mean, again, having, with Gravity, one of the things that I've noticed is that home care in particular, and home supports, not necessarily home care nursing, but home support, is sort of seen as something adjacent to, but not quite counting as healthcare, in that, for example, people have to pay for it. It's not covered under the Canada Health Act, so people have to pay for their home supports unless they meet these various criteria, in which case they get publicly funded home supports. So that was always surprising to me that, some of these things, and I mean, it was one of the reasons why I started Gravity, was like seeing patients who are in hospital effectively for the personal care and the meal delivery that they get in hospital and the medication administration, as opposed to the kind of medical level care that we need. And that, maybe having somebody do your housekeeping is not medical care per se, but at the same time, if that's the thing that somebody needs to be out of hospital, we need to find some way to balance that and figure that out. I mean, there's interesting models in other countries, like in Singapore, where they pay families to look after their loved ones, but then those payments go away if they come into hospital or something like that. So there's an incentive to try to have somebody at home, as opposed to here where it's like you go into hospital and suddenly all of your medications are paid for, all of your personal care is paid for, all of your nursing care is paid for, all of your meals are paid for, and as soon as you leave hospital, none of that happens anymore. So it's an interesting sort of, it's almost incentivizes hospitalization, and I find that dynamic quite challenging in medicine as well. Yeah. With those people who do remain at home, where you manage to put in enough supports and the family, has enough family caregiver assets or benefit, I guess people ultimately, do you find that there's sort of patterns that you see again and again, or do you see problems with them remaining at home and that they end up either coming to harm, like ending up in the emergency room, or ending up in institutionalized in the end?
I do see some patterns. I think sometimes the environment that someone is in can no longer be adapted to the point where it's conducive for them to stay. Like multi-level homes, lots of stairs.
You see patients and and it's like, okay, I have 72 stairs in my house and it's 2,000 square feet. So like, how do you even have that many?
Yeah, sometimes the environment it just no longer works for whatever reason, and we have seen people with more than 72 stairs. Sometimes they even access their home, so it's not unheard of. I think like with respect to problems, sometimes people can find it a bit of an invasion of their privacy, having somebody come at a time that is inconsistent from what is proposed, and there are often different faces, each time. So the current system that we have is not perfect, but we need to try and work within that right now, because that is what we are working with. I have also seen people do very well with kind of the right supports, whether it's somebody who's able to provide some companionship to also help with the isolation and loneliness that one may be experiencing, kind of energy conservation, so it's doing jobs for them or helping them even with their day-to-day care if they would be exhausted after trying to shower over the course of 3 hours, for example, and instead with someone's support it gets done quicker, and then they can do something more enjoyable with the rest of that time during their day. And then I do think that caregiver burden is a very real thing for people, and ultimately if we can help mitigate a lot of that, it kind of in the short game allows somebody to age in place and stay in their own home for the long game, which is what a lot of people want.
I see that from so many patients where they want to stay at home. It's just difficult for them to get the support they need, and their caregivers are either burnt out or are burning out, because the caregivers are often children or spouses who they're either spouses who have their own medical concerns, or children who have their jobs and their own children to deal with, and it's extremely challenging to sort of take that on. It's really a full-time job for them, in addition to whatever other full-time job they have. What about, like, in terms of utility, what have you found to be the most useful home care or home supports? What are the sort of things that you see being most helpful for patients? I mean, you mentioned kind of the idea of a mix of ADL support and IADL supports for people to sort of focus on what it is that they find most valuable, and then thinking about the caregivers. How can those home supports kind of help both the patients and their caregivers best? What have you found most useful?
I think that's a very person-dependent question. Sometimes I think having some respite, like a bit of a change of pace that allows the primary caregiver perhaps to get out and do whatever errands they need to do, or have some time for themselves, I have seen be beneficial. And also for the patients to kind of have a change of pace as well from their day-to-day, having a well-established routine, very important. But just having a bit of a change of pace as well, kind of even socially or with respect to the activities that they can do when they have a caregiver there who is perhaps from the public system or private, as opposed to their own kind of family member or spouse.
I think a change of pace is probably nice, and a change of sort of thought process. Maybe people have their own complex relationships as well and backgrounds and everything. So yeah, that's it. I mean, I'm thinking in particular about some of the things that I'm seeing more recently, the medication sort of machines, the medication dispensers, and then separately the sort of change in home supports, where there's this mix of public and private home supports, and a lot of people are kind of doing both. They have their public home supports and then supplementing it with private, in order to get beyond what the public system can provide.
Because I think generally my experience has been that with private supports, you can get more consistency, develop a bit more of a relationship with that caregiver, and subsequently that puts people at ease, having them come into their home, having them work with their loved one or with the patient. And there is a bit more flexibility and opportunity with respect to what can be provided.
Yeah, and also, I mean, speaking of the idea that everybody is unique and everybody's different and people's needs are different, and sometimes especially with a system that's supposed to work for everybody, or I guess if a system that's supposed to work for anybody isn't necessarily going to work for everybody, and so you have these unique individuals with unique needs, and you're trying to say, what you need is dressing support, eating support, ambulation support, bathing, and hygiene, or toileting, and so that box is perhaps not as helpful for some people as it is for others.
Yeah, I really don't mean to generalize. And kind of put in competition the public and the private system, because I think they can work synergistically very well. But thank you, brought me back to the point I wanted to make, which was that the public system, it is very task-based. And sometimes that misses kind of where we started this conversation of patient-centered care and getting to know the person, and how important that is kind of with that lens, with kind of the medicine that we practice. And we're lucky almost in some ways to have that sort of relationship and get to control our own schedules and see the same people over time, whereas for the patients and our sort of HCA colleagues, they aren't necessarily granted the sort of autonomy and decision-making capacity to have that, which is more challenging. We are definitely afforded that opportunity.
I find I struggle with it. I mean, I see patients at the cancer agency and in hospital, and even though I'm part of a very good team, and even I'm like, no, this is my patient, quote unquote, and it's my job to look after them, and I find it I'm even sort of almost possessive of them in terms of my my ability and my desire to be involved, which is not always, it's hard to sort of hand someone over and say, oh well, there's this other doctor that you haven't met that's going to be looking after you. And I can imagine on the patient side some sort of nerves and trepidation with that, especially because it's like there's no way you could do a handover of every detail thing. And so then you picture that for an HCA who's maybe coming in to do very personal care and trying to do a handover to the next HCA and saying, here's they have to turn this way, or they have a lot of pain in their knee, and that handover can be really challenging, I imagine, especially in a sort of rapidly changing system.
I mean, this is my personal opinion, that caregivers and HCAs are very undervalued in our society for what we expect. And the excellent care that they provide to our patients.
Yeah, exactly. I mean, a lot of the time it's like people will think that it's like the medications and stuff are really important, and often I'm sort of emphasizing just how little those move the goalposts in terms of somebody's happiness and somebody's functional status, and even in terms of somebody's prognosis, and we're just like, should we adjust their amlodipine by 10 milligrams? And it's like, well, that is not a particularly important change relative to quality of life and making sure that they can't fall, or getting somebody in for 2 hours a week to have a conversation or something, and to make sure they're okay. So the last question is the one that you had trouble with and you were curious what it is, but it's the magic wand question. If you had a magic wand to fix everything in healthcare, everything in healthcare for your patients, to fix everything for your patients, what do you think that magic wand would be?
I should have told my colleagues about this actually, to see how they would have answered this question too. But I think for me it just starts very small, and that the goal would be both in outpatient and patients, although we see a lot more of this in inpatients. I think we kind of touched upon why people end up in hospital, but would be to have kind of a general recognition of the importance of kind of geriatric principles and putting those into practice with all care and medicine kind of that's provided as a starting point.
Yeah.
Because it makes such a difference when people prioritize kind of the geriatric issues. It can shorten length of stay. It has, it's been shown to increase people's likelihood of getting back home after a hospitalization.
Yeah. Reduce risk of delirium.
Yeah. So there's kind of a lot of endpoints that are quite meaningful in our world, and I think having that kind of generally accepted would make a big difference.
Yeah, I agree, and especially, given the changing demographics, I mean, we both see sort of a very particular population. We'd be seeing these same patients even if they were very rare in the population. But the fact is they're getting more and more common, as time goes on, as that sort of, baby boomer retirement continues. That is going to be, even in a general practice population, so, Sky, my wife, as an emergency physician, she sees, a higher volume of geriatric patients as time goes on, and that the value of that geriatric principles in the emergency department is super helpful. I mean, it's good to see there's two separate emergency physicians now in Victoria who both have their geriatrics fellowship, like the care of the elderly fellowship, and I think that's extremely valuable because it's the sort of thing that they're going to see more and more of as time goes on.
Yeah, like I think we've identified that, and so we're trying to find these areas of overlap where we can work together to try and make a difference. Acknowledge that the population is getting older, people are living well beyond, the mean life expectancies, and our healthcare system needs to be able to accommodate that.
Yeah, it's going to be, I always think it's going to be like a pretty heavy 10 to 20 years coming up in healthcare, just demographically, as statistically as the population ages, as we start to see sort of 30 to 40% of the population be elderly, it's going to become more challenging to sort of do intensive care or very sort of medicalized care for people. That what they're going to need is more of the remain at home, trying to put supports in place and trying to do that, because otherwise the system's just going to get completely worn out. Yeah.
I think people have been saying that already for 10 to 20 years,
exactly.
and arguably we're already there. We're
exactly.
there already.
Yeah.
So
and it's not like it's a BC specific problem. It's not like it's a Canada specific problem. I think it's a worldwide problem, really. Yeah.
I appreciate you giving me this opportunity to share my thoughts
about
things, and
hopefully we can chat more. Okay, thanks very much, Ali.